Aesthetics in San Antonio, Texas. And we are very excited to bring advanced concepts in breast augmentation, and we're going to talk about what that is. But why don't you introduce yourself, Dr. Lopez? We're really grateful for your time today.
Yeah, thank you, Greta. I'm excited to be here. My name is Dr. Lopez. I am the surgeon and practice owner here at Amelia, San Antonio. And newly board certified, so also excited about that.
That's awesome. We are excited for you for that. And yeah, you're the perfect person to, I think, talk about advanced concepts in breast augmentation. And we were even discussing what that meant today. For those of you who are listening and you need the basics, I still would watch this. This is helpful, but this is like, what, class 2.0, or, a class that goes a little bit more in depth as to maybe the behind the why, revisions, placement, not the basics. And that's the kind of the way your brain works. Anyway, you seem to like to take things apart and understand. And so, yeah, what does advanced concepts in breast augmentation mean to you, and what would you prefer to cover today?
Yeah, I mean, we can go through a lot of different topics, but I think there's like two parts to it. There's like the newer research, because there's some myths about, like, especially when you talk about placement, like under versus over. There was some things that we used to say based on old research that is basically no longer true. So I think that there's part of it is that. And then there's also, like, I do a lot of revisions. One of the nice things about having recently trained is, I got to train with and take the best kind of techniques from like 20 to 30 different surgeons, and so like able to kind of put that together. So my brain does like that. There was a part of me that like thought I would, in another life, I would work for NASA, and so kind of figuring out like how to get people from their goal photos to, or like to try to like maximize their anatomy, understanding the limitations of that, like kind of really being able to predict how to go from one thing to the other. And then when things don't go exactly as planned, not every surgeon likes revisions because they're not straightforward, they're not cookie cutter. You have to kind of think through every single one of them. So that's one of the things that I really enjoy doing. So when do we need to use mesh? Like, what is pocket work? What are the different tools that encompass pocket work? At what point do we need to have like lifts, and how do we kind of fix all of the different things that like could sometimes happen after breast augmentation? So yeah, I'm excited to kind of go through all of it.
Me too. I really think I love helping women in through their journey at whatever point. And there's two different types of people in my mind. The people who don't need to know all the details. I just need to trust that you know the details. That's
Mhm.
probably more like me. Give me the 101 class, but you've taken all the classes. But which that's why it's so important to me to find someone you trust.
Mhm.
And then there's the other people who I think will love this whole session, which is I need to know everything about it. Like, the knowledge is fun for me to understand too. And so I'm excited to be able to go a little bit deeper for people who need to know everything, the people not like me. But you should
And
still trust
I
your
also
surgeon
think that
regardless.
I also think that one of the interesting things is, like, some people you see like offer like 50 different surgeries that they do, and like one of the nice things about the way I've been able to kind of focus on breast and body like contouring is, like, I basically am doing like variations of like 6 different surgeries, which gives me high volume even with just kind of being out. And with newer technology, like, we take preoperative pictures, we take intraoperative pictures, we take things. So I'm constantly looking at, like, when a 6-month post-op comes in, it's like, that looks great. What did I do? Like, did I do anything different for
Hmm.
this? Or, like, especially with the really hard cases, like I really enjoy like the really like asymmetric starting cases. Like, how do we get people closer? It's like, going back and saying like, okay, that was like, we got them 95% of the way there, but like maybe this like areola is a little lower. Like, what could I have done differently? And so kind of learning and iterating and learning kind of like the nuance behind how people's bodies respond to surgery.
That's so cool. Are you using like the meta glasses in surgery to film and take pictures?
I am, and even just something like, for example, like, I could talk hours about this, but like I joke, like, I spend hours thinking about like how to make a belly button look natural, and have tried a lot of different things. And like I've
Said no
spent
one ever.
I spent like hours thinking about, like, okay, like for asymmetry, like, how does the breast kind of change in like for a breast lift in a small patient, in a bigger patient. Like, so if the bigger breast is different than the smaller breast, so you can't kind of have to move marking. So there's all this like nuance, and we can get as detailed as we want, but like it's fun. Like I enjoy talking about it. It's something that I think about all day, every day, but we can at least get like the surface level of some of these like more advanced
Mm.
topics.
It's so great to know that there are people like you out there. Because I'm like, I would have assumed most surgeons would just want the, 22-year-old, no kids, no weight loss, A cup, perfectly symmetrical, boom, so easy. But it seems like you enjoy the challenge. And most of us are not the 22-year-old, no kids, perfectly symmetrical. So yeah, I'm really excited to talk about these topics. One of the first questions that kind of came in, I know this is probably one of the number one questions in bus mob, but how do I choose my implant? And not just the size, but the projection, the type. There's so many types out there. It does seem like there's new techniques being used more. I
Mhm.
swear we had over or under the muscle and saline implants for like 20 years.
Yeah.
And in the past 8 years, there's 97 new vocabulary words to use. And so I think that's really hard for a woman to go in and feel confident in their consultation. But so, how do you kind of guide the conversation to help her choose how to choose the right implant during a consultation?
Yeah, absolutely. So I think that there's a couple different things. And obviously there's going to vary like between personality types. So there's going to be some people who just want to like show a goal photo and be like, "How do I do it?" And then tell me what to do, which is fine. Like, but I think goal photos are huge. So number one is like if I like it's so funny how often I ask people like describe what you want, and they'll say like I want a very natural look, and then they'll show me somebody who has a very very well defined very full upper pull, and I'm like, ooh, interesting, because as a surgeon I would have called that augmented, and what you meant by natural is proportional. And so all of these words, like I spend hours every day thinking about, but I don't expect that out of patients. So first and foremost, like number one thing you can do is look at a lot of goal photos. I think the bus mob goal finder is super helpful. In a perfect world, you also try to look at people who have a similar starting body to you. So you can put in your height, put in your weight, like, because, obviously if you start with D cups, that's going to be a different kind of consideration than if you have no breast tissue, like, to speak of. And so, like, now it's also my job to kind of advise you on how that may or may not work and whether your goal photos are, like, doable with your anatomy or what are limitations. But that's first and foremost, like, number one. The second thing that I think is like a big patient kind of like decision is, as we're kind of going through there, like sometimes people are just open to like all the different brands that we offer, and there's a reason I don't offer just one brand. Is like there's no one person. There's not like everybody's the same person, so like different brands for different purposes. But a big decision point is like, do we like more upper pull or do we like more of like a natural transition? I feel like that's a pretty solid, like digestible, like question that I have for patients that's subjective. Like there's no one right answer. It doesn't matter what I like. This is your body. Like tell me what you like. Another thing that I like and we kind of tease this out in a consult, is do we like the look of like a little bit wider, a little bit more side boob, or are we really trying to get more of that projection? Because one of the things that I think is super hard to really dive into is profile of an implant. You see that all the time. How do I pick my profile? And the reason that's so confusing is that profile is width of the implant relative to projection, but also volume. And the fact that that's three different variables, like think about anything in life. Anytime you're like changing three things at once, it gets confusing. It's like too much to think about. So your measurements are going to partially determine, how wide we want the implant. But then from there, it's like, you may show me a goal photo with like an athletic look. And so then I'm like, okay, we're going to kind of really stick to your breast width. Whereas somebody else might come and show me like, I love side boob. It's like, we're going to go 2 or 3 like centimeters above your breast width. So there's no one size fits all. And that's why it can get really confusing. Even though I love Bus Mob as a resource and as a community, what people don't always see is that different goals are going to have different rules. So you'll have some people saying you have to stick with your, breast width. And that may be true for them. That may be true in their discussion with their surgeon, but that may not be true to achieve a different look. So figure out like what kind of look you're looking for, width versus profile, and then like general proportions. And then it's your surgeon, I think, who can kind of help you bridge the rest of the gap. Because I think in particular, like you've probably seen this all the time, right? Like people are like, that 300 looks massive on that person and then tiny on that other person.
Yes.
And The reason is it's implant plus breast tissue equals final volume. So you need to know what they had before. Plus, like proportions matter. So the visual I like to use for people is like imagine you had a little party hat and you put it on a Chihuahua, and then you put it on that same size party hat and you put it on a Doberman. Those are going to have same hat, totally different looks. And the same kind of thing applies with proportions. And so I spent like in residency and like my first year in practice, I used to quiz myself. I used to go and like be like, look at a before and after and be like, how do I think they got there? And at first, like, I was okay at it, but not very good at it. But after doing like thousands and thousands, like I've now gotten pretty good. We're usually within 50 cc's. I can be like, oh, to go from there to there, that's about 420, at that person's height.
Yeah.
But like, I don't expect my patients to spend hours learning how to do that. That's like where like my job as the surgeon to help kind of comes in.
Yeah, you just made me realize I'm like for Busma, we need to do some of those same implant size, but totally different look
Hmm.
side by sides of like two different women. I love it when clothing companies do that. Even here's what the medium looks like, here's what the large. I don't know. It's just helpful as a petite person too to see it. We need to do that. But I was going to ask you too. Do you recommend or not or like or not all these other technologies or tools that people use to try to choose their sizing, like the 3D imaging. Now there's like AI apps or sizers, or is there any other way that you find helpful, or do you actually think those are not helpful?
No, I think that they're helpful in the right context. So I'm going to kind of give you a couple examples. Like I think if you have a surgeon helping guide you with something like Vectra, Chrysalix, like one of those, like I think that that is super helpful because you can kind of get a sense of like proportions on your body. So obviously, like we just talked about how everybody's body is different, like super helpful. The things that are helpful-ish, but aren't going to be like the final thing, would be like when people bring in AI photos. And then we have to have a conversation of like, well, the AI gave you unrealistic proportions that you don't even have. Like it made your waist all of a sudden really narrow. And I think what you're actually liking is the overall thing that AI did. But like, I'm not going to break your ribs and flatten your rib cage. And like, we're not going to do some of the things that AI did. So like, that's not it's useful for me to tell you it's not realistic, but it's not super useful. The other thing that I think we use, it's not great, are like sizers. So like the sizers, I have like an example here. Um, they aren't made to actually recreate what your tissue does with the implant, and they just kind of tend to sit in front of the breast tissue, right? And like when I put an implant in, it's going to kind of stretch things in multiple different directions. So I also find that it overestimates projection, and I think that a lot of people get afraid to pick the size because it sounds big. It's like, ooh, I don't want to do 400. That sounds huge. And then when I put in a 400 sizer, I look like my chest is out to here. And then you see them come back and be like, I should have done 400. So like, I think that those are useful, but they have their drawbacks.
Yeah. Okay. That is very helpful because we're all looking for some hack and now AI and these apps and stuff. But yeah, so you're not going to get in the rib breaking game.
At least not for breast implants, because that's one of those advanced thing discussions that we talk about. So, closing the gap, common question that comes up,
Yeah.
right? I see it all the time.
Hmm.
And one of the things that I tell my patients is the same distance between implants is going to look different based on your rib cage. And I'm going to look down here for a second because I'm going to try to draw what I draw for patients real quick. But I usually will draw like a little animation of like if we use the same gap, but you have a flat rib cage versus that same gap if you have a rounded rib cage. So if you have a very flat rib
Ooh.
cage, look how close together those implants can look. And those are the people who in no bra, just standing there can have that like touching cleavage, which not everybody
Yes.
wants, but a lot of people do.
Yeah.
Um, you have that same gap, so same kind of distance, finger gap, but your rib cage is round. That is going to mean that no matter what, when you're standing naked, your breasts are going to point straight
Hmm.
out from the direction of your chest. And so you might be one of those people who, to get that kind of really close cleavage, you might need a bra to put it together. And then
Hmm.
also, like, this is where some of that advanced stuff comes in. Like, I have found that people with a very wide rib cage, rounded rib cage, tend to be the ones who don't do well with under the muscle. Their muscle angle is different. It pulls them really far apart. They feel like they have miles of gap, and it also just doesn't seem to drop like others. And so that's one of those, like, you don't see that pattern unless you're looking at like hundreds and hundreds of your own like before and afters, and like critically thinking about it too, because I actually put aside time on my schedule like once a month to kind of like closely evaluate like the numbers of the measurements, like how did these things go? Because if you don't think about it, you just kind of keep doing the same thing over and over again, and you could have good, maybe even great results, but you don't kind of reach that next level without kind of thinking and evaluating on it.
I feel so seen. I have never seen anyone do a drawing like that. And you just summed up why, for 10 years, with my under the muscles, I could not get them close together. And then the minute I came out of surgery of going over the muscle, they were touching. But my question, like, so that is, I totally see it. I must have a rounded rib cage. How do you know? How does someone kind of know that?
So, and it's not even just that. I think that that's where finding a surgeon who maybe has like a before and after, that like their before looks like you and the after looks like what you want, which is why I try to post like all different body types, all different types of results, even if not every result resonates with you, because I'm not sure that you necessarily can have enough context to necessarily know that, because it's not even necessarily the rounded rib cage. You might also just have a wide breastbone, and because your muscle attaches on the breastbone, if that's really wide, you're never going to get any closer than that. And so in general, like I do think that I'm finding that there's more and more of a trend towards like the return of the over the muscle, and we can talk about the nuance between subfascial and like subglandular. So I think that also gets really confusing, because a lot of times people lump them together as just like the two different options, and in my mind, like they couldn't be more different.
Yeah.
And so like I think that that's where like having a surgeon who does both. So like I tell people like I used to be 50-50, I now do probably 60-40, but if you go to a surgeon who only does subfascial, guess what? They're going to recommend subfascial. If you go to a surgeon who only does under the muscle, they're going to recommend under the muscle. And I don't think you get into the nuance unless you go to someone who has both things in their toolbox.
Yeah, well, let's talk about that. Can you go through again? Yeah, it used to be you're either over the muscle or under the muscle for so long. And most people in this country, especially, went under the muscle because of the lower risk of capsular contracture.
That's
With
right.
some of these new implants coming out and new techniques, that's less of a risk. But yeah, can you walk through the different options and then the pros and cons kind of why you would use one over the other?
Yeah, absolutely. So let's start with the historical side. So over versus under used to be the two options. The old school version of over, which is still used, and we'll talk about how it's now coming back a little bit, but the older school version of over was subglandular. So your breast is a gland. Subglandular means under most of the breast tissue, but still kind of in the breast tissue. And we think that because it was in the breast tissue, still kind of next to breast ducts and things like that, that it was able to get like microscopic amounts of bacteria on it that led to capsular contracture. In some studies, as high as 30%. And as you can imagine, nobody wants to do a surgery where 1 in 3 patients are going to have a complication. That's just like not acceptable for an aesthetic surgery that you get to pick. And so for a long time, we were just like, we don't do that. And we like the kind of dogma became we do under the muscle. Most people, when we say under the muscle, do a partial under the muscle. So the muscle kind of covers the top half of the implant, but the implant is like on the bottom. So it's kind of like, like that. So you'll also hear, to make it more confusing, the words dual plane or partially under the muscle. There is some nuance in dual plane that I won't go into right now, but like functionally, a lot of times those mean kind of the same thing, because the dual plane, muscle at the top, not at the bottom, partially under the muscle, all kind of clumped together. And it's probably one of the more common ways, especially like surgeons who trained over, like, let's just say like a random number, like 20 years ago, like when they were training, like that was probably the predominant way. And so like if they maybe found like that they're really good at that, or like maybe never like, kind of explored because they have great outcomes, like they're going to be the ones that like probably don't even think about doing the other techniques. The fascia, so subfascial, lifts up the covering of the muscle but leaves the muscle itself down. So imagine like the casing on a sausage, that like thin but strong layer. Your muscle has a similar layer that covers it. So you can lift that up so you're out of the breast tissue, but you're still in front of the muscle. And so to me, that's like the more modern version of under the muscle, or sorry, over the muscle, I should say. And in studies with all implants, even with like the 5th-gen implants, so we'll talk about 6th-gen in a second, but even with 5th-gen implants, that capsular contracture rate was more in like the 2 to 4%, which is similar to the like described capsular contracture rate for under the muscle. So with modern techniques of subfascial and with modern implants, at least from like the newest data, like I actually tell my patients, like, as long as you're doing all these new techniques, I don't think you have to pick under the muscle just for like if you're trying to like minimize capsular contracture. Now it becomes pros and cons, and this is where your goal photos come into play. Let's say you have a lot of tissue of your own, then it probably doesn't matter. You could go under, you can go over, like everything's going to be fine. If you have thinner tissue at the top, then we have to look at your goal photos. Do you like a smooth transition? In which case, if that's very important to you and you don't have a lot of tissue at the top, you might need the extra coverage of the muscle to do that. But some people will show me a goal photo where you can see like the arches of the top of their breast. Like you might actually benefit from not having the muscle there to kind of achieve that look. So that's where it becomes like a nuanced discussion, and a lot of those things are like subjective. It's like, what do you like? Who am I to tell you like that it has to be a natural look? Like that's ridiculous. You're not doing this for me. You're not doing this for anyone, hopefully, other than yourself, because that's one of the red flags that I sometimes see is whenever we have kind of conflicting people involved, that kind of not great.
Yeah. So are those the main over under options that you go over in a consultation?
They are, and you can get into like a little bit more of like the weeds if you're kind of like, there's some versions of dual plane where you can go over a little bit and then under completely, and then it kind of changes the way that the breast drapes over it. But those are the kind of main options. And the other thing that we talk a lot about too is like, what are your, in addition to what your anatomy looks like, what are your activities? Like, are you somebody who trains chest? Is it going to bother you if your implants move when you activate your chest? There's some early studies that say that under the muscle might have more lateral displacement. It's not great data, so like I don't tell people like to necessarily like hang their hat on that, but there may be some truth to the idea that like there's more wiggle room to the way that the pocket forms underneath versus like subfascial. At least I've seen a little bit of that be true in my own practice. Like I think the fascia becomes this like really hard endpoint over here at the side, whereas once you're under the muscle, you can almost just like with your finger kind of push things open because it's a nice plane. And so I think you have a little less control of where things stop when you're under the muscle. Personally, I'm not sure all surgeons would agree with that, but that's kind of been my personal experience with that.
What about making choices? Like, those are things to hopefully help reduce, revision surgery and things like that, but like aging and gravity. And are there choices you also talk about that are like, hey, yes, that might look great now, but I think you should think about this 10 or 20 years from now?
Yeah, I think with subglandular, they saw there was more like sagging. So it became a talking point that like, oh, over the muscle like sags. And I think that it's a little bit more nuanced than that. First of all, I do think there's a difference between subglandular and subfascial. I think that fascial layer does actually help lock things down. The other thing that I have noticed is that nobody gets to go from age 30 to age 60 with no change in their breasts. That's just not real.
I'm trying.
At least not without, some help. And
Yeah, a
so
lot of.
the things that I notice is like when you're under the muscle, I do think that the implant may have a little bit more of a tendency to stay higher. But then if you have a lot of your own breast tissue, your breast tissue starts to over time fall off of it, what we sometimes call like, people call it a waterfall deformity. I think deformity is not a good word, but like a waterfall effect where it looks almost like your tissue's falling off of it. So in that situation, like, yes, the implant stayed higher, but did it actually help you? Because you're still going to be coming, because you're not going to like the way that that looks of the tissue falling off of it, or like, Snoopy nose kind of look that people talk about. I do find that subfascial tends to move more with the tissue. So yes, I guess technically it's moving lower on the chest, but so is your tissue. So I think it like doesn't create that dramatic transition that sometimes can become more obvious as you age. I think that the other thing that is super important to talk about, and it's a good segue for our advanced topics, is the use of mesh.
Yes.
So I think that there are more and more reasons to use mesh. There's different versions, but they all are kind of made up of a similar stuff to like what we use our stitches that dissolve. So the body is going to tend to break this down over time, anywhere from like 3 months to a year and a half, depending on the type of mesh. And as the body breaks it down, it's designed to let your body grow into it so that the strength of the mesh you get to keep, even though the mesh goes away. And you'll see some that like look like they're little like slings for the implant. I tend to like to be able to customize it a little bit more. So I take a bigger piece and almost create like an internal triangle bikini. So I sew it in like here, and then it kind of wraps around the implant, and there's different sizes depending on exactly what I'm trying to do. But if we're worried about things like your tissue stretching, or maybe you've lost a lot of weight and you have very thin tissue and you need a big implant to fill up the volume, this is a way to kind of help support that and to kind of give you more longevity or maybe more like predictability.
I was going to ask about the weight loss piece, or just as a whole, you leaning, we're talking about more complicated things. I've always heard that the skin is a bit different and there are just more issues for people who have lost weight. What kind of questions should they ask? Or do you guys have a different consultation kind of talk track for that? Or should they always consider mesh?
I don't know. Never say never, never say always kind of thing. But I do have a couple things from, like I said, looking at my own data, looking at other people's data, like where we start having more of a conversation. So obviously, like if two people lose 75 pounds, those two people might not have the same changes to their skin. A lot of that's genetics, exactly how they can carry weight. But we at least start, for me, we at least start talking about mesh anytime anyone loses over 50 pounds, anytime anyone goes over an implant of 500 cc's. And then anytime we are doing a like revision lift. So if you've had a lift before and you notice like that bottom between the nipple and the fold just stretched back out, to me, that is your body saying, I don't have the strength to hold the implant up. I need a little bit of help. So those are all cases where we talk about it. The cases that are like, we're not gonna, like, it's not like a discussion, it's a, do you want it or not? Because I think you need to have it for this, is like when we're trying to do really bad lateral displacement where the implants in your armpit and we need to kind of lock that back down. When you've had bottoming out, which is where the implant falls below your fold and you may see like a double bubble where your old fold is kind of creating a bubble in the middle of the breast. Or if you just have really different folds, that can be a type of asymmetry that can really make it hard for things to look the same, because the implant tends to sit at the fold. So if you have one fold that's higher than the other, the side with the higher fold is always going to have more upper pull. So sometimes trying to get those folds even can be important, but you don't want to do that without being able to lock things down, or you can invite problems like bottoming out and stuff like that. So there are some people who like absolutely don't need mesh. Like if you are 21, all of your breast tissue is above the fold, and you want a 200 cc implant, I don't think you need mesh. Like I don't think, I think it just brings in extra risk. There's some people who absolutely need it. If you can like see through your skin and you're trying to put a 700 cc implant in, like you need mesh. And then there's a lot of people in between where it becomes pros and cons. Like I don't have a magic 8 ball. Like I can't say for sure, like, hey, with mesh, you're going to go 10 years. Without mesh, you're going to go 5. I wish, like maybe in the future with like AI and more complex things, but it's just kind of like best judgment based on like the whole collection of the individual.
I'm glad our 21, 22-year-old perfect girl, we love her too, but we're kind of talking about the other things. I was even thinking of tuberous breast while you were talking about that, weight loss patients. Like, what are some things, the common kind of anatomy things that make planning more complex when you're talking about breast implants or breast lift?
Yeah, so I think like in my mind, the things that make things more complex, or like you have to think outside the box, is asymmetry. So any difference from side to side, even if both breasts individually look good, like if they look different, that's hard to kind of correct without thinking it through, and you're going to almost inevitably do something different to one side versus the other to get things to meet in the middle. Tuberous breast is a good example. So for those who don't know, a tuberous breast is where you have fibrous bands, tissue bands on the inside that are basically taking your normal width breast and kind of squeezing it down. there's different versions of that where like you may have just a little bit of a triangular shape versus in the very extreme example, it can look almost like a tube sock with your tissue kind of just coming out from the chest. I tell people, imagine you took a hair tie and put it around the base of the breast. That's kind of what those bands are doing on the inside. And so, and that's a wide range of things. So if you have a mild tuberous breast, that could just be like, hey, maybe subglandular with a little bit of cuts on the inside. That's maybe that's like a good option with Motiva, or like subfascial. We kind of play around with like, ways to do that. I personally like to do an over the muscle with tuberous because you have this very tight tissue that needs to let go. So you want, in my mind, you don't want to put the muscle between the implant and the tissue layer. It rounds it out better. But if you had a really extreme example of tuberous breast and we're almost like trying to lower your fold, well, I kind of want to be able to lock in that fold so we don't lose control and have it like really fall down below it. Like I want to kind of lower it, but then have it stay where I put it, not just kind of like the implant gets to choose where your fold is.
So asymmetry, tuberous breast, anything else that is just like something that people should ahead of time can at least start to wrap their head around. This might be a more complex conversation.
Widely placed nipples are a thing that we kind of like, there are some things that we can do, but like people will have, if you kind of look relative to your collarbone, if your nipple is kind of in line with the like closer to the shoulder part of your collarbone, I can't put implants super close to the midline or I'll leave the nipple behind. So kind of show as a visual, if your nipple's in the center, then I can put the implant right next to your cleavage and like no problem. But if your nipple's over here, I either have to center it on the nipple, in which case you're gonna have a wide gap, or I have to kind of cheat it over a little bit, which is usually what we do, not too much, kind of like a just in the between. But if I go all the way in the center, your nipples are going to kind of be out to the side and be kind of left behind. So that's something that I think is a harder conversation to have. I have a little bit more control of that. If we're doing a lift, I can try to take more tissue from the middle and almost like pull the nipple over, but that one's a little bit of a harder one that can sometimes limit us in surgery.
Are there any people you see that are coming from, another practice, or they had surgery years ago, or maybe even multiple surgeries where you're just like, I can't do anything? Are there ever like a maximum amount of lifts, or like what are the reasons you would be like, I can't make anything better for you?
I think the number one reason would be unrealistic expectations. So I always say for any revision, whether mine or somebody else's, like there's two main criteria. I need to see what you see. So if I don't see what you see, like you're like, oh my God, they're horrible, they're so different. I'm like, those look pretty similar. I think there might be a little bit of body dysmorphia. That's a really hard conversation. And then there's like do I have a tool for it? So, if a breast bottoms out, I have a tool for that. I can lift it up, I can put in a mesh. But, if you like, I don't know, you had a complication and now you don't have an areola, like it's like there's sometimes it's like I don't have anything surgically, but maybe you can go get it like tattooed. There are ways, but I think sometimes not great ways to kind of like recreate certain things. The other thing that sometimes happens is if in between surgeries we realize you're a bad candidate for surgery. So like maybe with your first one you had this like horrible reaction. Like some people find out that they have this like inflammatory reaction like called like pyoderma, where anytime you make a cut it makes this like horrible wound. Like that becomes a really hard conversation, because it's like, well, we could try, but if you kind of healed over and you have an okay result, like I don't think we should. If your result, so it all kind of depends on where you are on that spectrum. But like, no, there's not necessarily like a number of like, as long as we kind of maintain good principles of like blood supply and like kind of think it through. But there are some times where, one other one. I do sometimes see patients who had cancer before and then had radiation. Pretty limited in what I know a radiated breast will do, and it won't tolerate like a lift as much as we may want to, even if it looks great. Like I just know that we could create like a huge open wound, and we shouldn't.
Yeah, no, I'm glad you mentioned expectations and things like that. I mean, bus mob is filled with 1,000 great stories of people going on to have a very successful revision. But, you know, my goal would be nobody has to have a revision anyway, and they nail it the first time. And so that's why you helping to answer questions ahead of time, that people have the right surgery with the right person at the right time beforehand. But I'm really glad that there are people like you out there doing lots of successful revision surgeries.
I do think that I agree with that. Like, I'd love to not have any revisions, and I do a lot of other people's revision work. However, I think it would be unfair not to also say like, hey, I have my own revisions too. That like sometimes
Mhm.
you think the tissue is going to do what you want it to do. It doesn't. It's nobody's fault. Like I hate when surgeons blame the patients. Like, oh, you didn't wear your bra 24/7. It's like that's not
Mhm.
why. Like that's
Mhm.
not the reason. Like things didn't happen. Like sometimes things just heal. That's not predictable on our end or the patient's end.
Mhm.
And I think that making sure that you, because no surgeon has zero complications, you want to make sure that you go to a surgeon who doesn't let their ego like try to gaslight themselves or you into thinking that it's not there. Like I see that all the time in my like when I see someone else's revisions. They're like, my surgeon said this is just normal. I'm like, well, that's not normal. Like I can't believe they said that. Like that's, you
Mhm.
know, if I had a patient who bottomed out, like I'd be like, it looks like your fold gave out, like we didn't think it would, but like it's there, let's fix it. So like I think the ability to say I see what you see, and I think that like there either is or isn't something that we can do about it, but like I hear so many stories about surgeons who are kind of just gaslighting their patients into thinking like this is the best it can be because they don't want to do a revision, and that frustrates me a little bit. I think that's unethical on the surgeon end, and I would never name names or badmouth, but like there are some that are more notorious for it than others.
Damn, thank you. Could I get a t-shirt that's like, I see what you see or something? I mean, that's, you're describing medicine and honestly anything where there's a specialty. That happens when I go get my car fixed. I'm like, no, I don't know, but you have all the power. And so I really appreciate that. Yeah, I mean, I've been with this practice for 23 years and I've had at least six breast surgeries. I don't blame myself. I don't blame my surgeon. I'm still a huge fan. I went into it with the right mindset, and life changed. I had two kids. I lost weight. I gained weight. Like, I think that's another reason I love Boss Mob so much, of helping people figure, you know, make it realistic. This is not a one and done. It lasts forever. It's perfect. It's flawless. Chasing perfection is something I even, you know, there for a little while when I was just exchanging my implants to go a little bigger and then a little bigger. I wish I had not done that. And I wish someone would have been like, you know, every surgery is a chance for an additional issue to happen. But it's still, when done in the right way and had the right conversations, plastic surgery can be wonderful for many people.
Yeah.
Um, yeah, I see what you see. I love it. No gaslighting. My kids have started to play this game, Imposter. I don't know if anybody in your office has played it. It's almost like a game. It's funny about gaslighting though. I did not realize my kids are great gaslight. Now they're like being taught how to fake and lie and make you think you're crazy. I'm like, this is a terrible game to teach our children, but it's funny. All right, you ready for a couple rapid fire questions
Yeah,
that you do
absolutely.
not know about? Um, and you know, just short answers. Like it's you and I are both lengthy, wordy
I'm
people.
not good
So,
at short answers. I'll try my best.
all right, a plastic surgery trend you're ready to see go away.
Ooh, I think that I've seen a few like skin tightening instead of a breast lift kind of things. I don't think that that actually works. I'd like that to go away.
Yes. Sleeping with a bra, yay or nay?
Don't think it makes a difference long term.
Damn it. At Amelia San Antonio, what's your most commonly used implant brand?
It's changed recently. It's probably it's probably Motiva at this point, but it's the Mentor Boost is also pretty high up there too recently.
Yeah.
Yeah.
How about the most common CC size?
Mm, I'm gonna cheat. There's like two different. Like if you look at the peak, there's probably two peaks. I think that like really
Yes,
common
there are.
is like somewhere like right around 300, and then another like really common peak is like in the like kind of 475-ish range.
Wow. Okay. What's something you say at every single consultation?
Uh, I will say some version of like if you had a magic wand, like what would you like changed?
Ooh, that's a dangerous question. I love that. What's the best recovery item your patients tell you about, or you tell everyone?
The one you don't buy. I think there's too many things out there. I think that we get talked into all these supplements, all these
I agree.
products, all these other things. Time, whole food, sleep, water are the mainstays of recovery.
That's so good. I could not have done without my neck pillow though.
I think it's
Um,
we give people a neck pillow as part of it.
what's your favorite surgery to do?
Tummy tuck.
Nice. All right, last one. What music do you listen to while you're operating?
Ooh, it changes a lot, but I think probably the number one would be like a T-Pain radio.
Oh my God, that's a good one. I like that. We actually, we're going to put it out soon, but just made a Spotify recovery playlist that
Nice.
we're going to post and give everybody. Our whole team had a lot of fun thinking through like what would we want to listen to if we were recovering from surgery. So music is important.
I agree.
Thank you so much for your time. I know it's late. Cold weather is coming for most of us. You have a child and a busy schedule. So we really appreciate your time always that you donate to the bus mob community. That was super helpful. I want to see that drawing again of my curved. I literally tried to take a picture of it when you're I curved rib cage versus flat rib cage. I learned something new today too. So I hope that was helpful for everybody. Thank you. You can always go follow Dr. Lopez on Instagram, dr.lopez.amelia. You're always posting good stuff on there, so we appreciate you.
Yeah, thank you for having me. Hope everyone has a great weekend and stays warm.
I know. Yeah, good luck. Bye.
Bye. Take care.